We are going live in 5, 4, 3, 2, 1. We are live now.
A very good evening, ladies and gentlemen. This is Dr. Harsh Trivedi, Associate Vice President of Pulse Pharmaceuticals, welcoming you to a very exciting evening where we are going to be discussing something which is new, metabolic osteoarthritis, an association of metabolic syndrome and osteoarthritis. We always knew that something of the sort exists. But having said that, probably we never dwelled on it much longer. We talked about reduction in the weight in individuals to ease off the symptoms, maybe to check the progression of the disease, but it was never bracketed as something. It was never given a particular name. Yes, today we are talking about it. Individuals with osteoarthritis having metabolic syndrome. And probably, I know I will stand corrected if I err somewhere, but as the individuals age and more towards their middle ages, these problems typically crop up, and it is probably more, it is tougher in the women in the who are in the perimenopausal phase, because per se menopause also brings about a lot of changes in the lipid profile, in the insulin resistance, the blood glucose levels, and so on and so forth. Now, how do these correlate with the osteoarthritis if it is there? Are they also a predisposing factors? We are going to learn all about these things. I know for once, I'm not getting into the shoes of Dr. Aarti, but yes, for one of the components, I know the waist circumference, the obesity of all the things which are used to define metabolic syndrome is definitely associated with osteoarthritis. So all in all, a very exciting package we have for you this evening. And I'm sure we'll go, much more richer in our knowledge on the aspects. And we also have Dr. Anish Aggarwal bringing in a whole lot of experience with his, indulgence in rheumatoid as well as osteo and the pain management. So we are going to be learning a whole lot from the panel today. But before I hand it over the panel, I will take a few minutes of yours to introduce my organization, which is Pulse Pharmaceuticals. Most of us know about Pulse Pharmaceuticals, but still, I would like to present a bit. I'm just taking a minute here to get on it, and I'm trying to share. I don't think my slides are visible.
No, sir. It's not visible.
Just give me a second. I think I'm having a problem sharing this. But nevertheless, you have given me the publishing rights?
Yes, sir, you are the host.
Oh, it seems it is not showing it to me. Anyways, I'll go ahead with this. It's the evening very aptly entitled "The New Vista in the Clinical Management of Metabolic Osteoarthritis," and as I said, it is jointly hosted by Pulse Pharmaceuticals and OrthoTV. To talk and tell you in brief about Pulse Pharmaceuticals, we have been in existence for past 26 years. We are a patient-centric company which believes in innovating, and we are driven by the passion for innovation and compassion for the individuals. It's an integrated pharmaceutical company with an inclusive growth model. We have world-class R&D and the manufacturing infrastructure. We have strong leadership team and operational teams across all the business functions. And we lead in the space of nano development, nano drug delivery systems. We also have strong presence in medical nutrition through Pulse NutriScience. And we are foraying in the immunocell therapeutics by developing novel CAR-T technologies. For this, we have joined hands with the Centre for Cellular and Molecular Biology based at Hyderabad. This is, in brief, what I have got to tell you about Pharmaceutical. I'll ask my colleague Alok to run a quick video which gives a better insight on just now what I have spoken about Pharmaceuticals. Can we have the video, please?
Others and passionate about its work. That is dynamic yet consistent. That is predictable and reliable. That goes the extra mile to deliver what is expected. Our business philosophy encompasses these very principles. At Pulse Pharma, we feel patients' problems, think, innovate, and do everything that it takes to deliver cost-effective solutions. We have a well-aligned leadership team and a highly motivated functional team to carry out our mission. We innovate and develop products with unique functional characteristics that help us serve our customers' needs better. We develop innovative business processes that help us improve our efficiency and customer experience. We have world-class infrastructure that includes an integrated R&D center and 3 manufacturing facilities that help us develop and manufacture high-quality differentiated products. Our research efforts are focused on developing nanotherapeutics, nutri-therapeutics, and cell therapeutics. Our operational presence is spread across India and 40 countries worldwide. We reach out to nearly 250,000 healthcare professionals in various specialties through our sales team of over 1,000 people and our partner sales force in various countries. At Pulse, we work with a real spirit of Pulse to bring about a positive difference in millions of lives. Because we are compassionate about people and passionate about our work.
Thank you, Alok, for playing this wonderful video, which gives us a greater insight on what Pulse is and is all about and is trying to do what. I'll quickly introduce our faculty for the evening. Ladies and gentlemen, we are fortunate to be joined by Dr. Vikas Jain, who is the CEO and founder of Aaroavam group of healthcare companies, Vapi, Gujarat. He is a MS in orthopedic surgery. In 1997, he's an M.B.A. from Washington University and IIT Bombay. He's an expert in 3D technology and has designed his own small joints for hands. He's a chairperson of 3D Committee of Indian Orthopedic Association, past president of Gujarat Orthopedic Association, past president of Rotary International, past president and trustee of Indian Medical Association. He is a highly accomplished change leader in healthcare. His passions include healthcare strategy, resource optimization, investment banking, mergers and acquisitions. He's an entrepreneur, as he would like to call it. He believes in value creation and in 3D technologies, utilization or use in orthopedics. With these words, I welcome Dr. Vikas Jain. Dr. Vikas Jain will be taking us through this exciting session on metabolic osteoarthritis. He'll be anchoring the program and will also be deliberating on various questions that will be put up by the audience. We are also fortunate to have Dr. Aarti Sahade with us, who is a consultant physician and diabetologist at Bharati Vidyapeeth Medical College and Hospital, Pune. She is a member of the governing council of the Diabetic Foot Society of India. She is an examiner of Pune University of Health Sciences, a DNP teacher and guide at Pune Hospital. She is also the chairperson of the Institutional Ethics Committee of Vishwanand Kendra, Pune. She is the honorary chairperson of the Lady Doctors Group of Pune. She is the organizing chairperson of Pune DEPSICON 2003. She has been a recipient of a Best Poster Prize in RSSDI 2015 for remote monitoring of diabetes and intervention. She has worked as consultant diabetologist at KM Hospital, Pune from 2003 to 2003, and she has worked in diabetes and endocrinology unit of St. Thomas Hospital at London. I welcome you, madam, and I look forward to learning from you on the association between metabolic syndrome and osteoarthritis. We are joined by Dr. Anish Aggarwal, who's a senior consultant and director, Institute of Rheumatology and Pain, Brij Medical Center, Gaziabad, Uttar Pradesh. Dr. Aggarwal is an alumnus of AFMC Pune and Kasturba Medical College, Manipal. He has received his training in rheumatology at University of Bath, England. He is uniquely qualified as a pain specialist and a rheumatologist, one of a kind in Asia Pacific region. He has comprehensive medical surgical management experience of rheumatology and pain with over 27 years of practice. Dr. Aggarwal has presented numerous papers and lectures throughout India and international conferences where he is a regular speaker. His areas of interest include osteoarthritis, medical arthroscopy, osteoporosis, medical management, pain management, and fibromyalgia. With these words, I welcome you, Dr. Aggarwal. I have always enjoyed listening to you, and today I have one more such opportunity. Thank you for joining us, and we look forward to hearing you all. It is over to you, Dr. Jain.
So thank you so much, Dr. Hirsch. Am I audible, please?
Yeah, you are, sir.
Okay, thank you so much. And thank you, Pulse Pharmaceuticals, for having organized this beautiful webinar and having an esteemed doctors across with Dr. Anish Aggarwal and Dr. Aarti Sahade there. So welcome all of you, both the doctors. On behalf of Pulse, I can also welcome you all. Let's, as an orthopedic surgeon, get to learn something new, because here the topic, as it says, is metabolic osteoarthritis. And when I first heard of this word, I was just wondering that we were thinking in terms of, and we learn and we work day to day in the orthopedics with so much to do with osteoarthritis. But then I was just wondering, what is the association of metabolism or metabolic disorders and osteoarthritis? And the more I dwelled into it, and I realized that yes, there is a lot of association, which subsequently Dr. Aarti and Dr. Anish Aggarwal would be able to show us in the presentation. Let me tell you that India has an incidence of osteoarthritis in tune of around 20 to 25% of the patients. This is a degenerative joint disorder, and it is the cartilage of the knee joint, predominantly knee joint, otherwise it's the other joints, which degenerate. And once it starts to degenerate, the joint loses its mobility, it becomes more painful, it becomes deformed as it becomes more progressive. And hence, there are a lot of things that you need to do as far as early diagnosis is concerned and prevention of osteoarthritis is concerned. We'll not go much into the details of what primary osteoarthritis is, as because our topic is predominantly focused on metabolic osteoarthritis. Metabolic osteoarthritis is often overlooked in a grand landscape of musculoskeletal disorders, and it warrants our attention due to its intricate interplay between metabolism and joint health. We have to have an emerging understanding of metabolic osteoarthritis, and it adds another layer of complexity. The inflammatory environment, which is created by the metabolism, is predominantly now coming up as a main cause of degeneration in the joint cartilage, which we'll subsequently try to learn from both the esteemed speakers. And we would like to have a good understanding between the connection of metabolism and osteoarthritis, which is a pivotal step towards a comprehensive approach towards the prevention and management of metabolic osteoarthritis. So once we go ahead, we would request Dr. Aarti Sahade to start with her first presentation so that we can learn what is metabolism got to do with osteoarthritis, which she's going to explain, followed by a presentation with Dr. Anish Aggarwal. So I request Dr. Aarti Sahade to start her presentation, please.
Yeah. Thank you, Doctor. Thank you, Dr. Vikas Jain, Dr. Harsh, and of course, Pulse Pharmaceuticals, for having given this opportunity to talk about, what should we say, a new topic of metabolic osteoarthritis. So where metabolism and osteoarthritis seem to merge. So just give me 1 minute time. Yeah, done. So as Dr. Vikas Jain said, that osteoarthritis is common, and it's going to be commoner as our population starts aging, and we have got a huge geriatric population. Essentially, osteoarthritis being a degenerative disease, you will expect it to increase in numbers, right? Yes. But then this is a picture of a normal and an osteoarthritic joint. The salient points here would be where you can have an articular cartilage, which is destroyed over here. You can see that the subchondral bone also is not healthy, and you have got a cystic subchondral bone, and the joint capsule has got thickened when you compare it with the normal side. And then you have some amount of synovitis, right? So these are the predominant changes that you will see. So there will be premature degeneration of the articular cartilage. It will become fibrillated cartilage. And then, of course, there will be altered bone turnover, which you will be able to appreciate on radiology. And you always will see the cartilage cap or of osteophytes, which can be seen on the radiograph. So this is roughly what we would anatomically and radiographically we should be able to visualize when I say osteoarthritis. And I think the prevalence is, as Dr. Vikas said, it's about 20-22%, and as I told you, it is likely to increase. See, what exactly is osteoarthritis? If you take it in a larger, with a broader vision, it is there is an increased cartilage catabolism, and then there is a decreased cartilage anabolism. So this is in a nutshell what is happening over here. And then to it you have got inflammation, and then because of that you have got joint pains, and then there is decrease in the hyaluronic acid. So this decrease in the hyaluronic acid is responsible for the stiffness of the joint, the synovitis, and the synovial effusion, and the muscle atrophy around, right? So these are salient points or pathological points that we get to see in osteoarthritis. So the moment I say osteoarthritis, I think I should be able to visualize these things, that the cartilage, there is something deranged in cartilage, that is, there is increased catabolism and decreased anabolism. So the turnover is a little skewed, right? In addition to that, there's inflammation, and there is in addition to that, there is decreased hyaluronic acid. Why do I require to remember all this? That is because there is a multiple pathway of, or rather there are various ways of production of a endpoint osteoarthritis as we understand today. And you need to address many of these pathways for patient's benefit. Or rather, if suppose I'm supposed to get, research on a, say, treatment molecule, then I should be able to actually identify, or I should be able to hit it on these pathways, right? That is why it is important. For physicians, it's a little common thing, metabolic syndrome, whereas for orthopedic surgeons and others, it might not be. Metabolic syndrome essentially is mostly visceral adiposity, okay? So there is abdominal adiposity. This abdominal adiposity is one which is metabolically active. So the one which is likely to produce pathology, right? So this is the one that begins, or that is the crux over here. And then it will give rise to insulin resistance. It will give rise to dyslipidemia. It is also likely to produce hypertension. So these are the salient points of metabolic syndrome. So what do you have? You have obesity, which you can measure in the form of waist circumference. So 88 in women, 100 in men. And then you have hypertension, say 140/90 and above. Then you have hyperglycemia. Earlier they used to say fasting hyperglycemia. Now practically we take it as anything. It might be IFG, IGT, diabetes, or increased HbA1c. And then you have, in addition to that, dyslipidemia. In our country, mostly it will be increased triglycerides and decreased HDL. All right. So these are all forms or components of metabolic syndrome. So you need to have at least 3 of the 5 criteria to call it as metabolic syndrome. We still are not exactly in the know-how of where it starts, where does it begin. But I think many of the studies done so far have actually pointed it to the abdominal adiposity. So probably this abdominal adiposity is the one from where the pathology starts. And how do I get this abdominal adiposity? Probably I get it from when I was in my mother's womb. So it's like, you know, according to the Barker's hypothesis, it starts off at the primordial state itself. So this is what is talked about metabolic syndrome. Now, osteoarthritis is also a part of metabolic syndrome, though it might not be a defining criteria, correct? In the olden days, we always used to think that osteoarthritis is because of the extra load on the knees. And so it is more of a pressure rather than the pathology that is responsible for it. No, there is a phenotype, right? There is a phenotype where you have patients who have got features of metabolic syndrome and they also have osteoarthritis. So you have different kinds of osteoarthritis phenotypes. Like you also have different kinds of metabolic syndrome phenotypes, all right? But it is one phenotype where both of them will join. And that is the subtype of an OA where you have predominant metabolic syndrome. So my question is, why should I know about it? One thing is, when patients have metabolic syndrome, they're more likely to develop OA. That's a given. So you need to take care of their weight. You need to take care of other comorbidities. That's also given. But it is better that we do remember that there is an entity called as metabolic syndrome and osteoarthritis phenotype. How do I know about it? Or is there any evidence for it? Of course, there is an evidence for it. There are lots of studies. There are more than 15 studies for that matter. There have been lots of studies, and out of these 15, 16 studies, at least there are 14 which show an association between metabolic syndrome and osteoarthritis. And if you now look at the literature actually goes back from, say, 2004, and they've been speaking about metabolic syndrome and osteoarthritis loosely, to now the latest one probably would be June 2023. So you have a lot of articles, reviews written on our studies, written on this phenotype. And now of late, you have got, of course, much more data that is available. So now what exactly joins these two, metabolic syndrome and osteoarthritis? One is very simple. It is chronic low-grade inflammation. That is very easy to understand, which is present in metabolic syndrome, and it is also present in osteoarthritis. So it's likely that both of these have gotten together, and then maybe 1 + 1 might not be 2, it might be 3 or 4. That is probably what is happening because there is an elevated expression of pro-inflammatory cytokines in these patients. So there is systemic inflammation and there is probably also local inflammation. In addition to that, the individual components of the metabolic syndrome, for example, say hypertension, that also has some amount of the pathological impact on the joints. All right, let us see how it happens. We know that with increasing blood pressure, usually there is vasoconstriction, and this vasoconstriction occurs in the middle and also in the smaller arteries. So we know that cartilage doesn't have its own supply, right? It doesn't have its own blood supply, but it gets its nutrition from around. And then you have capillaries that supplying the subchondral bone, you have capillaries that supplying the synovium, etc. All of them will undergo vasoconstriction, and they essentially produce hypoxia. And remember, hypoxia is likely to produce what is known as autophagy, which increases, that is apoptosis, right? And there is some kind of autophagy where the cells which are not salvageable are taken away. And then actually it is supposed to instigate chondrocyte repair, right? But then what happens here is that the chondrocyte repair does not happen very well. And then the osteoarthritis progresses because of loss of or increased catabolism of cartilage. That is what happens. In addition to that, hypertension, like say IHD, is a low-grade inflammatory state by itself. So that again has a systemic effect on the joints. Now coming to dyslipidemias, I told you dyslipidemias, there is increased triglycerides, increased free fatty acids, what we call as FFAs, and these FFAs actually will reduce PPAR gammas, these are nuclear receptors, all right? And then with these free fatty acids, when they undergo metabolism, okay, there are a lot of oxidative stress that occurs. And it also activates the metalloproteinases, matrix metalloproteinases, what we call as MMPs, all right? So these two, that is PPAR gamma agonists, PPAR gamma nuclear receptors are not stimulated very well as they are required. Plus there is increased oxidative stress, and this will lead to less of proteoglycans. There is increase in the that is induced NOS, that is NO synthase, and there is decreased collagen type 2. All right, there are lots of types of collagen. It is collagen type 2. There are 58 types of collagen. Okay, and these cartilage is made up of proteoglycans, collagen, etc. And then again, increased inducible NOS will actually hamper chondrocyte repair. It will produce catabolism, and there is decrease in the collagen 2 and proteoglycan availability. So the anabolism again takes a beating. So there is again the cartilage repair is not properly done. Osteoarthritis progression will occur. So this is how dyslipidemia by itself is likely to affect the joints. Okay. And then you have, of course, obesity, which is the sine qua non of metabolic syndrome, right? Of course, it is also because of overloading on the knee joints, where there is proliferation and differentiation of myoblasts that will occur, lead to muscle weaknesses, decreased proteoglycans that are likely to occur. Most important, obesity again is a low-grade inflammatory state systemically, right? Obesity produces insulin resistance, IFG, IGT, and type 2 diabetes frank are likely to occur in these patients. And then there is increase in the TNF alpha and increased again MMPs, decrease in the collagen type 2. Again, the chondrocyte is the one which takes the hit. The repair does not occur. The catabolism is more, which will increase the pace of osteoarthritis progression. So then you have hyperglycemia frank, which also again you have got what is known as AGEs, that is advanced glycation end products. So increased sugar, where will it go? It goes and attaches itself to different proteins, and those are known as glycation products. Now these advanced glycation end products are seen in various tissues, including synovium, etc., especially vessel walls, right? So these are likely to produce increase in the oxidative stress, right? Again, insulin resistance, as I told you, increases TNF alpha, increases inflammation, and MMPs. That again, increase in the MMPs will decrease the proteoglycans, collagen 2, and the chondrocyte repair is not properly happening. The anabolism is not happening. That leads to osteoarthritis progression. So these are all different mechanisms that are present, that are occurring in a patient who has got metabolic syndrome. So they all occur individually. The components will work individually, and all of them will work together. So you have all of them working together ultimately. For example, overloading, insulin resistance, increased IgE, TNF alpha, muscle weakness, mechanical environment is lost, low inflammation, correct? Oxidative stress, decrease in the PPAR gammas, autophagy, etc. So all of them at the end of the day will decrease collagen 2, type 2, and decrease in the proteoglycan, and the chondrocyte is not repaired properly, or there is impairment in the anabolism, which will produce osteoarthritis. So this is the end result of the metabolic syndrome. So I think I have explained to you what exactly happens in the metabolic osteoarthritis. I'd be available for any queries if they are at the end of the session. Thank you for patient hearing. On to you, Dr. Vikas.
Yeah, thank you, Dr. Aarti. That was really good, very deep.
Thank you very
And
much.
it must have been too deep for most of the orthopedic surgeons, who are more used
Yeah,
to
I tried simplifying it
only,
as much as possible.
only looking at the X-rays, CTs, and MRIs, and then
Yes.
you could actually take the pathogenesis of the entire metabolic osteoarthritis right at the microcellular level. And I'm very sure most of the orthopedic surgeons must be scratching their head, where are we going now? Have we to learn so much in orthopedics as far as osteoarthritis is concerned? So there are doctors like who will take care, and I think let the metabolism be handled by the physicians and
Yes.
rheumatologists.
In fact,
We
that is the point I was going to make, that, when you see osteoarthritis, just check whether it is metabolic osteoarthritis. You need to take care of metabolic syndrome if you want your patients to improve. That's it.
However, the message is that the orthopedic surgeons also will have to now look at every osteoarthritis patient, keeping in mind that there is a association of a metabolic syndrome, and we should not miss on that. So my request to all the orthopedic surgeons who are listening to this, please now start thinking in terms of metabolic syndrome and try to link the metabolic aspect also to the osteoarthritis. However, we have one more esteemed faculty and speaker here, Dr. Anish Aggarwal, and he'll tell us more about the early diagnosis management and how to go about managing the patients with metabolic osteoarthritis. Over to you, Dr. Anish Aggarwal.
Thank you, Dr. Vikas, and thank you, Dr. Aarti, for making my job so simple. I just have to take it from where you left it, and it's already, gone so deep that I actually have to try and make it simple and, something that is more easy to understand in day-to-day clinical practice. That is what we are actually going to do. So the net has already been, laid out by Dr. Aarti. There is so much happening as metabolic osteoarthritis. What we need to do is now resolve it and get out of the net. So I'm going to take you slowly, as simply as possible. And I think by the end of it, we'll find it not as heady as Dr. Vikas thought it is. And we'll be able to resolve the issue for us. So at the word go, the word metabolic syndrome and metabolic osteoarthritis is now a coined term. And this is something we have to start considering in our practice. So let's look at the pathway as such. What is this metabolic osteoarthritis altogether? So we have with osteoarthritis an activation of inflammatory pathway. And we also know that inflammatory activation can be by the activation of COX pathway and NOX pathway. This could lead to pain, and pain itself can lead to osteoarthritic progression. We are also aware that this would lead to increase in inflammatory presence of interleukin 1B, TNF alpha, and MMP3, and this has already been highlighted by Dr. Aarti for us. Again, a decrease in cartilage anabolism has been very clearly highlighted, and this is what happens when the osteoarthritic progression takes place. And on the other hand, we also have activation of inflammatory immune-mediated pathway that could obviously lead to a lot of inflammation, and this leads to cartilage damage. We have T cell, activation of T cells against cartilage collagen type 2 and increase cartilage catabolism. So we have decreased anabolism on one side, increased catabolism on the other side. This will obviously lead to increased level of cartilage degeneration. And then we also have the lack of lubrication or the reduction in hyaluronic acid synthesis in the joints, which takes place due to osteoarthritis. And this is not just a lubrication, this can also lead to the proliferation of differentiation of myeloblasts, lead to muscle atrophy, lead to increased friction. And this again, as you can very well understand, is going to cause the cartilage degeneration and progression of osteoarthritis. So this is the basic layout of what really is our problem. Now, if we hit this one by one, I think we'll be able to find a good solution to what we are at. Right. So in this pathway, what are we normally doing? And this is the day-to-day practice, which everybody can understand. We are attacking it with NSAIDs. We are trying to give some effect with glucosamine and chondroitin sulfate. We've been using MSM. We've been using devil's claw, rosette, and other things. Now, what are these things doing? They are targeting pain and inflammation directly. Then we have collagen peptides, which probably help in, cartilage anabolism. Then we also have immune-mediated pathways. We really don't have much we are doing about it. We have hyaluronic acid, which we are giving orally or intraarticular. And this is what is, directly affecting the effect of reduced hyaluronic acid. So these are the targets we presently have in our armamentarium. And this is what we are using in our day-to-day practice. Right. But what are the issues here? We have these treatments, pharmacological as advised. We have analgesics and NSAIDs. We've got specific anti-OA treatments, which are also known as Cisadoas, hyaluronic acid, diacerin are well certified. We have nutraceuticals like chondroitin sulfate, type 2 beta. Then we have methyl sulfonyl methionate, methane. We've got glucosamine and many other things in this basket. Non-pharmacological exercise and weight loss is a very important thing that has to be done. Then finally, also surgery is one of the modus operandi when we have to treat our patient with osteoarthritis. But what are the limitations here? We know about the GI, and the renal safety issues of NSAIDs. We also have to look into the dependency sedation effects of the analgesics, which would obviously lead further to musculoskeletal degeneration. Then we also have the targeting of pain and inflammation only with most of the drugs which we are using, and they're not addressing the progression of the osteoarthritis, which we all know is a progressive degenerative disorder. Again, the third problem here is that most of the drugs which we are using, like collagen peptides, the dosage is very, very high. It's a food substance, and you have to take it in bulk. But the dose prescribed or given to us in tablet form is very low and minuscule, and it clearly works as a placebo. There is no treatment option to manage cartilage catabolism. There is poor compliance and lifestyle issues for exercise and weight loss, and we all understand trying to address that to our patient is a big game. And then, as far as surgical is concerned, we may have a good surgeon at our end, but on the other side, patient may be unfit for surgery. There will be non-availability of good facility in a lot of areas of the part of the country, and then the patient may be unwilling, which is an absolute no for surgical intervention. Then let's introduce you to certain things which we can do, and we have for us native collagen type 2, which is known as colavent N2. Now this is a unique collagen, and it's most abundant family of proteins in extracellular matrix of connective tissues. Type 2 collagen is the main structural protein in the cartilage and provides tensile strength and toughness to the tissues. It is in natural form, collagen is quaternary structure consisted of folded triple helix, a long polypeptide chain, and it is called native type 2 collagen. And this is how it is biologically active form. Type 2 collagen is extracted from chicken sternum and again strict controlled manufacturing processes. And then it has a triple helix structure. Again, this is not something that concerns you so much, but just to introduce what they are. So let's see how it works. So it is given to understand mostly that if you are giving collagen or type 2, we are trying to replace the cartilage by providing adequate collagen, but this is not exactly how type 2 collagen works. When you administer this orally, it reaches the pia patches in the small intestine. There it is recognized and leads to release of inhibitory cytokines from the pia patches, and these are the interleukin 1O and TGF beta. And differentiation of native T cells into T regulator cells turns off the immune response and the T cell attack to indigenous collagen type 2 in cartilage. So it's an immune mediated process. It is not a direct absorption of collagen and then leading to cartilage production. It's immune mediated suppression of the inflammatory damage that takes place to the cartilage. So systemic immune response leads to suppression of T cell attack against collagen type 2 in the cartilage. So one exogenous collagen is targeting safety of the natural collagen which is present. It's not a direct deposition. So this offers cartilage protection and reduce inflammation in the and pain. So just to understand what is the difference between type 2 collagen and hydrolyzed collagen, which we were earlier using. So it is a native form in type 2. We have a triple helix structure. As you can see, it's a well-defined structure here. While denatured is something that is absorbed in this time. It is cut into small peptides and then it is absorbed as proteins basically. And would it really convert into something significant as increasing your cartilage mass or improving the cartilage anabolism? That is a question here. So type of collagen is type 2 and this is non-specific. Absorption of type 2 collagen is not there in the gut. It is just stays in the gut and goes out. So it is just something that is going to stimulate or trigger an immune response and it's not expected to be absorbed. While hydrolyzed collagen is absorbed and the mechanism of action is immune mediated as I explained to you. And while in the hydrolyzed collagen, it is anabolic. The main effect is decreasing collagen degeneration or destruction. And while the collagen which we have denatured is actually trying, it is intended to increase the collagen production, which I don't know if it really achieves or not. But another big problem is the dosage. The type 2 collagen, the dose is only 40 milligrams, which is easily doable. But try to do 10 grams of hydrolyzed collagen. That is something which is pretty difficult to get a compliance from a patient from. So understanding all this, we are very clear that this is one armamentarium we can use. So I've described most of the things collagen type 2 can do. It's a unique mechanism. This is known as oral tolerization, and it reduces joint pain, stiffness, and improves physical function. Clinically proven to reduce various cartilage degenerative biomarkers. It's effective in 40 mg dose. That's so nice, and offers comprehensive cartilage protection. So, and it's been approved and it is being used in various countries. Next target would be Boswellia serrata gum resin, which is basically known as aflapin. Now, this gum resin has got 20% ACPA, which is 3-O-acetyl-11-keto-beta-bisphenic acid. Now, this is a substance that basically targets the inflammation. So, how does it do that? It is a selective and potent 5-LOX inhibitor. So, as you remember the pathway or the cartoon which I put up in the beginning, where we are looking at the inflammatory response, the COX and the LOX, 5-LOX pathway, which is going to be causing direct damage or progression to the OA as well as the damage to the cartilage. So this suppression of leukotriene formation is there. Reduction formation of inflammatory mediators like interleukin-1 beta, TNF-alpha, and ICAMs. The presence of these have been very clearly highlighted by Dr. Aarti. So this leads to reduction in inflammation. We are targeting inflammation not of only the osteoarthritis, we are also targeting the metabolic syndrome related inflammation here. Inflammation of, inhibition of matrix metalloproteases, and this thereby obviously reduces the cartilage damage and improves the formation of the cartilage, thus thereby delaying or preventing the progression of osteoarthritis. So what are the real effects of aflapin? Just to cut it short, it's anti-inflammatory action, selective and potent 5-LOX inhibitor. It has effect on TNF-alpha, interleukin-1 beta, and ICAM inhibition, cartilage protection thereby, and matrix metalloproteases inhibition, and counterprotective action, anabolic effect, as well as it stimulates the GAG and collagen matrix formation and significantly reduces pain thereby in just within 5 days. That's what has been claimed. Now let's look at another thing which is pretty famous and it is taking the world by the storm. That is curcuma longa extract, which is a novel and potent protected formulation designed to enhance the viability of free curcumin. Curcumin is something which has become very, very widely accepted treatment and something we all have, are hearing a lot about it. offers highly bioavailable form of sustained release curcuminoids and prepared using unique preparatory hydrophilic and lipophilic balance, that is HLB technology. And the Curculife contains 3 types of curcuminoids, that are curcumin and dimethyloxycurcumin and bis-demethyloxycurcumin. So basically, we are targeting a good bioavailability of curcuminoids, and this thereby exhibits a good bioavailability, clinical proven for its enhanced oral bioavailability. So this is what the product is all about. It was 48-fold higher free curcumin levels in blood vessels from other formulations. So that is, so as far as delivery of the drug is concerned, we have a novel product here. The mechanism of action is again COX enzyme inhibition. We've got decrease in MMPs and reduce in oxidative stress, thereby reducing the progression of osteoarthritis. So we also know that we have another product, that is the hyaluronic acid. It's a polysaccharide and collagen peptide, which is a combination present in Mobili. It demonstrates better efficacy than individual hyaluronic acid alone. How does it do that? That is still not said very clearly. Maybe the bioavailability is better, or maybe the combination works in a synergistic effect. It is shown clinically efficacy in improving joint mobility, reducing synovial effusion, and increasing muscular strength and safety. So if we are improving mobility, we are targeting obviously the lubrication or the hyaluronic acid content of the joint, and thereby increasing mobility and reducing stiffness. And it is novel form of hyaluronic acid, having an ability to get absorbed, well absorbed, and GI absorption is very good. 69% is absorbed through the intestine, while we have this cartoon showing 38% from duodenum, 22% from jejunum, and 9%. Documented mechanism of intestinal absorption, as we know, stimulates endogenous hyaluronic acid synthesis. Now, is it replacing the hyaluronic acid as we come to think of it? No, it is not. It is stimulating the endogenous synthesis. So what we are doing is directly increasing the environment of the joint, and thereby improving the OA condition. And it modifies the expression of gene association with connective tissue changes and joint pathophysiology, which is known as the nitrogenomic study. And this is something I'm not very familiar with, but yes, this is what has been said. Now let's look at these things. We can combine all these things. One is type 2 native collagen. We can aflapin, boswellia, we can combine hyaluronic acid, we can find, and curcumin. When you combine all these, you get a synergistic effect. And for this, we have this combination which is available, and it has been studied in 100 patients in grade 1 to 3 KL scale. And they were 21 to 75 years of age, 100 such patients. And we have the scores which tell us that things are looking good. We have the VAS pain score, where we have in 2 months 6.5 to 3 drop. That is pretty significant. And we also have the mobility index, where the range of movement and flexion is improved over 2 months. And we also have the KOO score, which is the knee injury and osteoarthritis outcome score, where we are seeing significant improvement in the various aspects of pain, like symptoms, pain, activity of daily living, sport and recreation activity, and quality of life. So in conclusion about this drug, in short, it's good to use the synergistic effect, and it's a capsule which can be given preferably before bedtime. So again, easy as far as the patient compliance is concerned. And so how does it really target the pathways which we were talking about? So this is the cartoon which is covering the areas which we are talking about. We have the inflammatory pathway here, the COX pathway, the LOX pathway, which is very nicely managed by curcumin, which is there in Curculife, as well as aflapin, which is the boswellia product. So we thereby manage pain as well as reduce inflammation. We also have aflapin affecting on the cartilage anabolism. We have Volavent, which is again going to target the immune mechanism, as I mentioned, collagen type 2. And then we have mobili, which is the hyaluronic acid, which is stimulating the increased production of hyaluronic acid. So all said and done, we have targeted all areas and we've covered all areas that are there in the metabolic pathway or the pathway of osteoarthritic progression. And thereby we have a targeted product on our head. So with this, in brief, osteoarthritis pathway can be managed by the combination of these 4 products. And the metabolic part, we have to obviously not forget the diet, the exercise, the medication. And that is, again, a very, very big issue as far as the practice is concerned. Trying to explain patients the diet and what kind of exercises they should do and what medicine they should and avoid taking and things like that. So that is something which is very important. So with this basic coverage, let me just get to what is the international guideline, the ACR and the Arthritis Foundation guidelines, the ORC guidelines, as we say, 2019 that were put forward. Now these guidelines are very specific about a lot of things, but let us understand how they read. Because we all are literate people, we look at the guidelines that are being put forward. First and foremost, these guidelines have been made as a direction. They are not your rule of thumb. They are a direction of you to understand that these are the things we understand about. So when they have said strongly against a certain product, they are very clear that the product is, our opinion is against it because there are no good studies. It does not mean that you cannot use it. Conditionally against means that, yes, we don't have adequate study, we cannot give our opinion properly. So in that process, they put a lot of things which are there in the guidelines. So hand, knee, and hip OA. And we all know that glucosamine and hydroxychloroquine, methotrexate, everything has been tried. Really nothing much is coming out of it. But then it is all an individual judgment. They have very clearly said it, that you have to understand what is best for your patient in what condition. Are we looking at primary OA? Are we looking at secondary OA? Are we looking at metabolic OA? Are we looking at something which has unilateral condition or a global condition? So there are a lot of ifs and buts, and then obviously you try to use everything in the armamentarium in order to get a good result for your patient. So with this, thank you so much for a patient hearing, and I'll hand it over to Dr. Jain for the follow-up of this session. Thank you.
Thank you so much, Dr. Anish. I think that was a very elaborate presentation, predominantly focused on the medical management of metabolic osteoarthritis. Predominantly you were focusing on the early stage of the osteoarthritis, where there were some molecules which could be very helpful as far as counteracting the inflammation in the arthritic joint or the osteoarthritic joint is concerned. So we all as an orthopedic surgeon also understand that the process is the inflammation there, and this inflammation is augmented and aggravated by certain very nicely explained by Dr. Aarti as to how the metabolic syndrome augments this process of an inflammation locally as well as systemically. There are a few questions that I would like to put to both of you esteemed presenters. The first question that I would like to put is to Dr. Aarti. What is the main component of metabolic syndrome associated with osteoarthritis?
Well, it's a simple but yet difficult question to answer. See, the most important thing probably would be the abdominal obesity. That is where actually the metabolism goes wrong, right? It is the abdominal adipocytes that they are responsible for the rest of the things that come. So from there you have leptin, and from there you have adipokines, and then the cytokines, which are probably responsible for the rest of the things. So if you ask me which is the pivotal point from where it might start, I would still put it as abdominal obesity. I don't know, Dr. Anish, you have any different idea? Agree with me?
I agree fully with you. It's probably the seed that is abdominal obesity is the seed of the whole issue. Understand that very clearly. Yeah, but there are so many, again, it flows down.
So also not only obesity per se as a mechanical stress onto the load-bearing joints, but you also should be thinking in terms of lifestyle diseases, should try to rule out hypertension, should try to rule out the metabolic syndrome. So that's the way you can look at it. Yes. We are very fond of using lots of painkillers, NSAIDs for the osteoarthritic management in the early stage. So what do you think, Dr. Anish, which would be the first line of therapy in osteoarthritis? And if NSAIDs, which NSAIDs? Or if you think there's something else that you think from your point of view as a rheumatologist, can you elaborate?
Right. So again, osteoarthritis per se is not a singular entity by itself. If you look at it at certain points of time, there is going to be an inflammatory component which is pretty high. There would be a non-inflammatory condition also, which will be actually, you'll be dealing with neuropathic pain. So you have to choose, what is the right drug to be used at the right time for your patient. So, for example, if there was a study by Flanagan and his colleagues where they were talking about what is the type of pain in most of the, I'll call it cold osteoarthritis, which are not very active. There is pain there day to day. And they found neuropathic pain was the main component in 80% of the patients. So this is where we can go by not going in for NSAIDs. We should be going for analgesics here if the patient needs any support for that. So again, my first approach is to understand that are we dealing with active inflammation, or are we dealing with an inactive situation where the patient is having a degenerative condition which is difficult to, which is causing the pain and disturbed mobility and other functional losses due to osteoarthritis. So here we go by giving NSAIDs for as long as it is required, and definitely analgesics when we feel NSAIDs are no longer required. Now let's get to NSAIDs. Now it's a very big ball game. I can go on and on. It's going to be hours and hours of speaking. Be ready for something really great from my side. But NSAIDs are not just a single word. You can start with the earlier types of NSAIDs. It's something like talking about cars. You can't say that Maruti and Mercedes are the same things. So we have to really differentiate between COX-1, COX-2 inhibition, selective COX-2 inhibition. The further drugs which are there, we have certain NSAIDs with the chiral purity, and very specialized NSAIDs are there in the armamentarium today. So we would definitely choose the best for our patient, which has a direct effect or the least, adverse effect and direct effect on the joint inflammation. And for that, etoricoxib is a very good selective COX-2 inhibitor, and etodilax and all these products are also there, which we can be using for a chronic condition. So again, we have to look at something which you're going to be prescribing for a long time and not causing major side effects. So that's how we go with the NSAIDs. Yeah.
Okay. But when you get a patient and you're very sure that this is a metabolic osteoarthritis, what would be your first line of therapy?
So first line of therapy would be just not one thing. I'll be obviously targeting their pain and this thing. I will be giving this combination I was talking about, all right. But I would be also targeting, the different aspects like the obesity, the diabetes, if there is anything, or even if the patient is a pre-diabetic, if you have a high fasting insulin levels or something like that, we do check for all that. We're looking at hypertension, we have to manage it, lifestyle changes. So osteoarthritis management is not a one-man show. It is a team effort. We have to have our physiotherapists, our dietitians, our counselors, and Dr. Aarti's team also, and as well as rheumatologists. And then obviously, last but not the least, at the top of the table or the head of the table, we'll have an orthopedic surgeon sitting with us and helping us out there. So it is not something which you can say, this is my first prescription, this is my second prescription. It is something you have to hit it with all we have and hit it from every side. That's the way we go by.
So the patient is all confused, which doctors should he be visiting just to get his osteoarthritis managed, right? Anyway, Dr. Aarti, I would like to ask you if NSAIDs can be avoided in metabolic osteoarthritis, or do you think there is any cardiovascular risk associated with it?
Yes, of course. It is associated with it. No question about it. More than that, see, these are patients who are, as I told you, have insulin resistance, hypertension, diabetes. So they make a very good recipe for an impending renal dysfunction. That is what we are very worried about, right? So their kidneys are very vulnerable kidneys. So these NSAIDs are, is something we would like to keep them very far from our patients. So yes, we are worried about them, and then I don't think I would use them for a long time and without monitoring. Some pharmacovigilance is required in these patients, no question about it. Yes.
Are there any studies that you have seen or gone through which shows clear correlation? So you were telling in your presentation about around some 15 studies.
Yes,
right?
there are 15 studies which are done. Yes, some of them show very clear cut correlation between osteoarthritis and metabolic syndrome. Let me confuse the orthopedic friends a little more. Okay, when I say metabolic syndrome, you visualize a roly-poly man with osteoarthritis limping and coming to your office, right? No. And then obviously he's a patient probably for both TKR and bariatric surgery. No, that is not it. See, it is a lean man. Mind you, it is an apparently lean man with a little paunch. Okay, with a little paunch, who says that he has got pain in the knees. He's the one who is likely to have metabolic osteoarthritis. Okay, so if you think your patient is not obese, obviously his weighing scale is not going towards 100, and then it's not metabolic osteoarthritis. No, it's not like that. It's still metabolic osteoarthritis. So far as studies are concerned, yes, there are 14, 15 studies. And let me tell you, the last review that I read, okay, it's a beautiful one that comes in current opinions, I think, of obesity. It's a very good review. And they have done a kind of a meta-analysis of all the findings of the past few studies. They're extremely good studies done. Yes, the quality of studies also is good.
So, Dr. Anish, what do you think would be your closing statement as far as metabolic osteoarthritis is concerned? What is the message that you would like to give to the orthopedic surgeons? Maybe say just 5 salient points which would be like important for the orthopedic surgeons to understand, and they should take guidance from this topic what we discussed today for metabolic osteoarthritis.
Yeah, so in short, firstly, we need to understand that metabolic osteoarthritis is not mechanical osteoarthritis. That is very important, because what we think, as Dr. Aarti rightly put, the weight and all, we look at it is because of that. It's that metabolic syndrome per se, which is playing a big part. So in such patients, we will be having joint pain. We'll be looking at the various aspects of metabolic syndrome there, and we would definitely go ahead and prescribe the treatment or the armamentarium we've used today. We talked about various things, because they will need a chronic long-term prescription for support. And then we are obviously not targeting using NSAIDs and other products that would be causing those adverse effects. So we have to reduce the pill load. We have to reduce the burden of treatment, which is quite a big problem. So with that in hand, definitely this is the way forward. And then we are looking at primary, widespread osteoarthritis, where you have hand and finger. This is where we use this product. Early stages of osteoarthritis, we use these products very well. And once we have something which is advanced, then obviously surgical intervention is the answer.
Okay. Thank you, Dr. Anish. Dr. Aarti, would
yes, I'm there. You
like
hear me?
to
Maybe
give
you're not able to see.
closing statements?
Yeah.
I think, Dr. Aarti, I think we have some problem with the audio line there at your end.
Yes, there is some, but I can hear you very well.
I think, Dr. Aarti, your two speakers are on. I think you're logged in through two
No,
equipment.
that's because there's some problem with
Now
the.
it is better. Now it's all right. Now it's all right. Yeah.
Yeah, right. Fine. Yeah, I'm sorry about it. Yeah.
We can have some closing statement from you.
Okay. Correct. Yeah. See, first one is prevention. I think most of the orthopedic surgeons will get patients in the trauma room, right? OR, etc. So all our next gen needs to be taught about diet, exercise, maintaining their weight, etc. So that probably is the first thing that I would emphasize on, because after all, both osteoarthritis and metabolic syndrome, though they have genetic connections, they are very much influenced by environmental factors. So you might be able to reduce some of them, and then you should make every effort to do them. That's the number one. Number two, as I told you before, see, remember, metabolic syndrome is not something that you will find in very obese patients. So actually, abdominal obesity, for that you will have to do a BMI, but most important is waist circumference. So look at it from that point of view. And if you think you have a patient of osteoarthritis with abdominal obesity, I think you need to refer it to a bariatric physician, or if the patients, you have got to look for hypertension, etc., other metabolic parameters, and then try and treat them simultaneously and give them some time to recover from them. The osteoarthritis might become better, or rather, at least the progress will be slowed down. So I think this is my what should I say, closing point. But the most important thing is, every time you have an opportunity, I would like you to go for prevention. So when patients are admitted in the hospital, probably you have the best time where they are likely to listen to you, they're likely to comply, and that is a time probably when you need to talk to them about prevention.
Thank you, Dr. Aarti. Thank you, Dr. Anish. I think when we started to discuss this topic as metabolic osteoarthritis, a lot of orthopedic surgeons across India must be wondering as to what they would get to learn, what they would get to hear. But I'm very sure they would have acquired in-depth knowledge about this entire topic. The gray areas as far as osteoarthritis pathogenesis is concerned, as far as the management is concerned, has been much cleared out. We know much in a black and white now as to how we have to look at metabolic osteoarthritis. I would hand over to Dr. Harsh Chaturvedi to conclude this meet. And I would thank Pulse Pharmaceuticals. Thank you, Dr. Anish, and thank you, Dr. Aarti, for this excellent meet.
Thank you, Dr. Jain. It was really exciting listening to Dr. Aarti and Dr. Anish, and the dimensions they have brought about, to the osteoarthritis. Yes, we were aware of the certain things, and certain things have been put across very succinctly and in a very emphatic manner. That is what. And one of the most important things that I have realized is the way Dr. Aarti has clearly pointed out that the lean individual with the paunch complaining of pain in the knee is the one is most likely to be suffering from metabolic syndrome and osteoarthritis, and is likely to have more complications. Yes, so we need to typically move away from our well-rounded figures, patients with well-rounded figures, so to say, and look at the other individuals as well. Probably they are more susceptible today. I've seen that even over the past decade, the diabetics are not so heavy, these days. They are also, many are lean individuals. They turn into, maybe it's the metabolic syndrome leading further, progress from maybe pre-diabetic stage to a full-blown individual. And they tend to suffer quite a bit more. So it was very interesting learning these facets, and they were very practical. And I hope that these will be used in the days to come in managing the patients better. With these words,
that's very true, Dr. Harsh. And just to conclude, it is very true that we get a lot of patients who are osteoarthritic patients who come to the orthopedic OPD. A lot of patients do have hypertension, they have lipid disorders, they have obesity, they have diabetes, but then we have not looked upon them as a metabolic osteoarthritis, So that labeling did not happen. It's just that the patients did come to us, and now that we have a in-depth knowledge about associating that with a metabolic syndrome, maybe some form of a medical management can be augmented. Also, a lot of preventive measures can be done. Also, lots of lifestyle modification can be added. And all this together can give a holistic management to the patient in the early stages of osteoarthritis. But once they have a joint which is badly degenerated, badly cartilage has been eroded, and we need to take them in terms of think in terms of a surgery, the whole game changes then. So yes, this was a really important topic, and I hope across India, for a lot of orthopedic surgeons who are listening to this particular very interesting talk, which was brought by Pulse Pharmaceuticals and two eminent speakers, Dr. Anish and Dr. Aarti, would take back a good message back home.
Thank you so much, Dr. Jain and Dr. Aggarwal, Dr. Aarti. It was a pleasure interacting with you, and we look forward to many more such learnings from you. Thank you so very much.
Thank you, everyone, and good night, everyone. Thank you.
Yeah,
Dr. Anish, you're from Manipal?
Yes, I'm from AFMC and then Manipal. I was just listening to the fact that in Pune.
I'm from Manipal.
Yes, so that is where I'm from.
I don't know where I passed in 1991. 1990 December, that is.
I also passed in
89, 90 I was there.
I was in Manipal. I passed out in 90.
Which year? 91
from Manipal.
Sir, can I take your leave? I have some important work to do. All of you, I'll be in touch with all of you. Thank you so much.
Yes. Thank you, doctor. Thank you. We can stop the live recording. We have concluded the program. We can stop the live recording.
Right. So let's get in touch. I think there are certain things we associated some because we were there in Manipal same time you did your
same time.
I did my MD under Thota, but not Thota and his group. So that was it. I did my pain management and anesthesiology.
Okay. Phanindranath Thota. Okay, I'm Dr. Kundaji's student.
I understand. Nice meeting you, ma'am. And let's keep in touch.
Yes, nice meeting you, sir. Nice meeting you.
Once again. And
yes.
So it was a good session. And
yes.
It
was a very good session. Very good session. Yeah. Thank you very much. Thank you. Take care.
Thank you, ma'am.
Thank you, sir. Thank you.
Yeah, we'll indulge into it again.
Yeah, if you can, please share me Dr. Vikas Jain and Dr. Anish Aggarwal's number.
Certainly. One of my colleagues will share those with you. Right.
Yeah.
Good night. Thank you so much.
Thank you very much.
Yeah. Bye-bye. Thanks, OrthoTV. It's time to fall off.